Thank you. So just give me 1 second. Let me
Yeah,
slides ready.
perfect.
Mm.
Juveria, while you're doing that, I'll just kind of welcome everybody to this space. And thanks for joining us. So my name is Shauna Jewer, and I work as the Community Engagement Lead for Nova Scotia Health with the initiative called Roots of Hope, which is about building capacity in our communities to support those that are thinking about suicide and or grieving from suicide. So I know many of you today and others are new to me. So thankful for everyone that has come here today. And thankful for Dr. Juveria Zaheer to share a little bit about her research through CAMH on understanding the impacts of COVID-19 had on those that were thinking about suicide during that time. And so thank you, Dr. Zaheer, for being here today. And I'm going to take myself off the spotlight and give you this space. And so for the next little while, Dr. Zaheer will be sharing her slides and information about the research and how to go about participating in it. And then we'll follow up with a Q&A afterwards. So we'll just, if you want to just type chats in the chat your questions, that would be amazing. Okay, thank you, Dr. Zaheer.
Thank you so much. And please call me Juveria. I'm so grateful for everybody's time today. I was meant to co-present this talk with my colleague, Gina Nickel, who is a person with dual expertise, so lived experience as well as research expertise, who has been a part of this study as a co-investigator from the very beginning. Unfortunately, she's not feeling well today, but she sends her well wishes and wishes she could be here. I'm here to talk about a research study that we're doing across the country and hoping that people may be interested in participating. My name is Juveria. I'm a psychiatrist in Toronto at the Center for Addiction and Mental Health. I actually grew up in Newfoundland, which is very different, of course, in Nova Scotia, but have East Coast ties as well. I am the medical head of the CAMH Emergency Department. So that's a place where it's a standalone psychiatric emergency department where people can come in and get help and care and be treated with dignity and respect on what can be the hardest day of their lives. And then my program of research focuses on suicide and suicide prevention, co-led and really well integrated with people with lived experience, really interested in how the expertise of people who have lived experience or have had family members or loved ones with lived experience navigating the system can help improve the system and can help improve care for people with suicidal thoughts and behaviors, a group of folks who tend not to get very good care in a lot of places in a lot of ways. And so that's just sort of our focus. So I wanted to start just by talking about suicide and the COVID-19 pandemic. I think when everything started, I'm sure everybody kind of remembers where they were in March 2020 when the whole world seemed to shut down. And initially, there was a lot of concern that potentially suicide rates and rates of thoughts of suicide would go up. And this is a really nice paper that was published around that time. And one of the things that people were saying is like, look, the risk factors for suicide seem to map on really strongly with what's happening in this pandemic. So, for example, people may be experiencing worsening mental illness. And if they have experiences of suicidality, it may be very difficult to get care because they may not be able to go to their outpatient care provider or they may not be able to go to group. In terms of other factors, people, I'm sure we all remember during the pandemic, were experiencing really significant financial stressors. There was a huge uptake in domestic violence because people, women, non-binary folks, children may be stuck in places where they're not getting out and people are under stress. So there were elevated rates of domestic violence across the world. Alcohol consumption was a really interesting risk factor for suicide. And in the pandemic, at least in Ontario, people's alcohol consumption went up by about 25% in the first 6 months after the pandemic. And
What is their boys basketball Sunday? Is at 4 o'clock tomorrow. The boys basketball Sunday.
sorry. And then, and so that can be a risk factor for suicide. And then really importantly, I think things that we can all really identify with, feeling isolated, trapped, lonely, really significant feelings of bereavement and trauma. Thinking about people who, like many of you, work in healthcare, how stressful and scary that was. In terms of access to means, we had people prescribing maybe larger amounts of medication. So you have more medication at home than you wouldn't normally. People with eating disorders also had quite a lot of triggers during the pandemic because a lot of their routines were taken apart. And then also there was a pretty significant uptake in gun purchasing in North America as well. And we know that's a risk factor for suicide. And the media reporting is really important. I think sometimes in media reporting, if we paint suicide as something that doesn't have a solution and only has one cause, for example, like the pandemic, it can be very triggering for people, and it can cause contagion effects. So this is what people were worried about. But what the data showed, and it's really interesting, is that there wasn't really that uptake in suicidal behavior or death by suicide that we were expecting to see. And this is consistent with other times of sort of mass trauma or global unrest. So, for example, suicide rates went down during the two world wars. But although suicide rates were quite stable, it is not a surprise to any of you that people were experiencing increasing distress. And survey data increased calls to distress lines, increased reported suicidality, and we saw increased rates in suicide in certain groups. So, for example, Black men and racial minority groups in the United States, women in Japan, young people as well across the world. And so, one of the things that we really wanted to do is that when you're trying to understand something as complicated as suicide, yeah, numbers are really helpful. So, it's important to measure the numbers and to see how the numbers are changing in one group or the other. But unless we talk to people who are experiencing suicidality either right before the pandemic or during the pandemic, it's impossible to know how to best help people and how to best support people and to understand how all of the factors that we named kind of in a theoretical way, how it actually applies to people's lives. And so this is a grant that we applied for called Suicide in the COVID-19 Pandemic, Understanding Canadian Stories, that was funded by CIHR. We have a really big team, lots of collaborating groups. We have collaborators across the country, people, very importantly, with lived experience as full and equal members of our study team. We have people who have expertise in geriatric psychiatry, people who have expertise in child psychiatry, people who have expertise in addiction. So people who have expertise in emergency work, mood disorders. So I think we really want to understand people across the sort of the span of what suicidality can look like for different folks. And my co-lead on the study is David Rudaller, who is an excellent scientist from Ontario Tech University. And he and I have done other kind of large Canadian, sort of pan-Canadian studies on things like how do psychiatrists practice, or how do family doctors practice, or how do people provide care? So we were able to leverage the network that we had to roll out a study pretty quickly, which we were really excited about. So one thing that we sort of started with as like a supposition was that the COVID-19 pandemic had a disproportionate impact on those with pre-existing mental illness. And for all groups, it was linked with worsening mental health, substance use, poor access to care, trauma, bereavement, financial stress, and social isolation, which are all risk factors for suicide. But we had no clear understanding about how this group was actually feeling and what they thought could be helpful. And so what our goal was is to understand the experiences of Canadians at risk for suicide and their perspective on mental health care to develop evidence-informed practices and policies. And so we wanted to interview over 100 people across the country. We've interviewed, I think Elisa can correct me, but I think something like 83. And the research areas are understanding the link between suicide. Like I think sometimes we frame suicide, and all of you are experts in this area, as just a function of mental illness. But we all know that social factors and economic factors and family factors and life factors are just as important. So we really wanted to understand the intersection between suicidality and these other factors. We were also really interested in deferred and displaced mental health care due to the pandemic, and we had some interesting findings in that area that maybe sort of reason for hope or cause for hope. And then we are also interested in existing disparities among marginalized populations. So, for example, men die by suicide more than women do. How did the pandemic affect men differently than women, potentially? Gender, disability, age, and sort of other exacerbations of this group, thinking especially about older Canadians, what does it feel like if you're in a nursing home and you can't have any visitors? And I think about even my own grandparents who are in their 80s and now 90s, and how they said, I'd rather live a couple of years less if I could see my family more and didn't have to be so isolated. At the same time, just so scared of getting sick and our responsibility to protect our elders. So really interested in different age groups. And then some of the work we'll present to you here is around our findings with younger Canadians and how the experience was so incredibly stressful for them as well. And many of you may be in your 20s and 30s, and there's a big chunk of time in the pandemic where your life was really turned upside down. Or those of you who are parents, my daughters are now they are, oh my goodness, 11 and a half and just turned 7. But when the pandemic started, they were 2 and 6, and it took up a large part of their lives. So in terms of participants and sampling, we're looking at people over 18 in Manitoba and Ontario, and over 19 in British Columbia and Nova Scotia, just because of different research ethics requirements across the different provinces. And so these are the 4 provinces we're looking at. Of course, we wish we could interview across all provinces, but these are provinces we had existing relationships and we thought that they were really nicely represented. We would have loved to have Quebec as well to get another perspective too. And we wanted to make sure we understand sex, gender, and intersectional considerations. So youth, middle-aged, and older adults, people with who had difficulty accessing mental health care, and those traditionally excluded from research. We wanted to make a really big effort to recruit them. And those are ethnic minorities, gender diverse people. And then even things like, men in rural areas who tend to be excluded for studies or older adults. So really wanting to have a sample that represented what our country looks like. And so this is I won't belabor this, but this is just what I just mentioned. And also, I think sometimes historically we think of suicide as just related to depression, but suicidality can occur across all kinds of diagnoses, schizophrenia, trauma, personality disorders, addiction. So we wanted to make sure we had people that were not just kind of one kind of person, health status. So we know that for people who had pre-existing health conditions, the pandemic was extraordinarily stressful because those are the folks that, may feel that they were at highest risk of having serious consequences develop from COVID. SES, and there's a nice quote coming in our study a little bit later about how it was with a young person said, it's very different if you can isolate, in a nice house on a nice cottage with your whole family and everyone has their own room rather than if you are 6 people in a 2-bedroom apartment. That feels very different for folks. And then sexual orientation and identity. Excuse me, just 1 second. Oh, sorry, just allergies. So our recruitment strategy, we had general and targeted recruitment, social media, our research registry at CAMH, which is a really effective tool, and then recruitment in clinical settings, and recruitment by clinicians. So the difference there is recruitment in clinical settings is like you can put up a poster in in a mental health care setting, and then people can kind of look and take the information down themselves. Recruitment by clinicians is a little bit different. So that's like if you were a therapist and you have a patient, and in some of your work, you've talked a lot about suicidality in the pandemic, and you can say, hey, there's a study I heard of. If you're interested, here's the contact information for them. Are you okay if they contact you? And then you are not involved in that process after that. So we always want to keep our clinicians, like our team separate from clinicians, but it's just like, hey, if you're interested, here's something that might be cool. Self-referral. So this is kind of what we just talked about. So self-referral versus service provider. And we just did a podcast in BC that maybe we can share with your group as well and the person who did the podcast, we would always protect confidentiality, but they disclosed that they did the study, which is really lovely. And from her perspective and from Gina's perspective as well, sometimes when you do research with people with lived experience, they kind of get tacked on at the end or they're sort of asked questions, but they can't contribute. One of the things we're really thrilled about in the study is that we have co-design. And so the process of doing the study it's very conversational. It's telling your story on your terms. There is, of course, financial compensation for participating. It's not like, you come in and we just ask you questions about suicide. It's like, tell me about yourself, your life, who's important to you. What are your memories of the pandemic? What helped? What are your values? What do you want the system to look like? So very conversational. And because of our dual expertise clinician and the developing of our advisory council, really participant focused is our goal. And so in Nova Scotia, we can even see the different recruitment pathways we have here. Of course, recruitment on X is very challenging right now for all kinds of reasons, but so we're trying to focus more on these other pathways. So recruitment by clinicians, clinical settings, and other pathways as well. And so you might wonder, like, what happens if I say to someone, hey, here's a cool study. So basically, Elisa, who's on the call, who is the real brains of the operation, she's brilliant and organized and polite and empathic and the best. And she will contact the person. They'll do a screening survey. And that can be done by phone or it can be done online. And that's a really nice way that we can get a lot of information about someone so we can leave the interview to be much more conversational. So we don't have to, when we interview you, we don't have to be like, what are your diagnoses? How long have you been in the hospital? How much money do you make? All that stuff is kind of done ahead of time. So the interview is much more conversational. And then just to note that, we want to have a diverse sample. So in general, especially in Nova Scotia, anyone who comes to us probably will be interviewed. But in Ontario, for example, if we had a lot of young women in their 20s, we had to say no to a few people because we wanted to make sure we had a diverse sample. So, but I think in Nova Scotia, and Elisa can correct me if I'm wrong, at this point, we'll take anyone who's interested for the most part. And that might change as we get closer to finishing up our sample. And then we are, so my program of research is based on suicide and suicide suicide prevention. We have a lot of suicide safe research approaches. We've done suicide research in all kinds of populations, young people, older people, people with schizophrenia, people with addiction. Our research team has done, I would say, over 100, hundreds, several hundred interviews with people qualitatively across different studies and care providers. So we have a lot of expertise in this area and make sure that the people we work with are safe and well supported. And then we have a suicide risk screening tool before and after, just to make sure that everybody feels safe. And again, in the qualitative suicide research that I've done over the last few years, with a very, very large sample, probably, I think across all studies, like close to 300, there's only one interview we've ever had to stop and say, hey, I wonder if maybe you don't feel safe enough to keep going. And then we did a lot of support and made sure the person had resources and made sure they still got their financial compensation for volunteering. So I think in general, people feel, and I think as clinicians and people who have experience, this, when people feel heard and respected and have a chance to tell their story, it tends to be quite, I don't want to say therapeutic because it's not the wrong word. It's the wrong word in a research context, but it can feel really good. And it can help people feel better and safer. And so it's about a 30 to 90-minute interview. Some people prefer phone, some people prefer video conference. We always make sure it's the participant's choice. And some people prefer camera on during video conference, some people prefer camera off. So lots of flexibility. The first half, we want to get to know you. So what's your life history before the pandemic, including mental health, experiences of suicidality, help seeking, who's important to you in your life, what worked, what didn't. And then the second half, we focus on experiences during the pandemic. Similar questions. And we have some folks in the study who had never had a single suicidal thought before the pandemic. We have people who had suicidal thoughts quite a lot before the pandemic and then actually had an improvement of suicidal thoughts early in the pandemic and then maybe worsening thoughts later. So all kinds of different trajectories. And I think it's really important because no two people have the same story. And then just very quickly wanted to present some of our early findings. And this is the sample of folks who are younger Canadians, so 30 and under during the pandemic. And what they told us is that the pandemic represented the seismic shift in the balance of life for young people who are managing competing personal, educational, and professional and social priorities. So the example that I give is I'm a 42-year-old person. When the pandemic started, I was in my late 30s. And yeah, I had children and it was stressful. I had a job and was working in an emergency department, but I had already kind of established a lot of the framework of my life. And so losing 6 months or a year when I had an established framework didn't feel as scary. But when we talk to young folks, if you're 18 or 19, your life is changing so much already. And 6 months or a year when you're applying to jobs or university or, negotiating relationships or moving out of your house or moving back into your house, it represents a huge shift and a huge proportion of your life. It's like my 7-year-old recently said to me, I don't remember my life before COVID because her whole life was kind of COVID. And so I think for young people, it's really, 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 it really hits them really hard. Young people with suicidality during the pandemic are not a monolith, and the shifts affect them in different ways through different lenses of gender, culture, social and socioeconomic status, previous experiences. And, we know that in Nova Scotia, the rules and regulations around COVID and keeping you safe were different than they were in some other provinces. And so we found that too, like you may have different experiences of lockdowns and different experiences of feeling safe or unsafe in terms of your health. Then he described a path forward into recovery. And so I think that this is really important. So I think of the over 8 interviews we've done, it's very rare for someone to say, I wanted things to go back to how they were before the pandemic. Like what we hear is that this experience is kind of transformative and altered who I am. And what does recovery and resilience and safety look like for me incorporating my experiences? Like, how do we build better rather than going back to where we were? Because the world had a lot of problems beforehand, especially for people experiencing mental health and suicidality. And young people, I think, had really important perspectives on mental health service delivery based on their experiences seeking care during the pandemic. So these are some of I'm going to just rush through these because I want to make sure that we have time to chat. I'm just doing a time check. But lots of disruption, distress, anxiety. You can see these, and I'm sure many of you are reading these and are like, oh gosh, this feels so much like what I experienced, or some of these felt like what I experienced. And then these are some of the other sort of important pieces that as those stressors built up, there was building intensity, worsening mental health, problems with system navigation. And these are the things that they identified as transforming mental health care. So trauma of a disrupted future. You can see, I think the people's words speak so much more beautifully than I could ever speak for them. So I'll leave these slides up for a little bit, and I won't read them all because you don't need to hear me reading. But you can see this that and these are all, of course, this is all anonymized and confidential. The person talked about getting their dream job and packing up and being so happy. But then life changes and the pandemic happened. Um, I was trying to apply for work because I just finished my undergrad, but I didn't have enough experience. And then when I got interviewed, it was hard to get past that. People weren't hiring, especially in retail. This one I thought was so meaningful. Like all of my life, my mom talked to me about university. That's always been my goal, to go to university, meet people, learn everything. But when I learned it's just going to be online, I was thinking there's no way I'm going to do that. And these young people, and I'm sure many of us can identify with it. I was lucky to work in an emergency department. So at least 2 days a week, I felt like myself. I was with my team. We took all the necessary precautions. We provided healthcare. But my other days, I used to go into the office and meet people and have coffee. And I was just doing 10 hours of Zoom meetings every day. And I'm sure a lot of us can identify that too. And so I was beating myself up. Why can't you just focus? The days felt extremely long. And then existential distress. I'm sure we all felt this too, feeling very trapped, not knowing what my life would be moving forward. Is this how it's going to be for the rest of my life? A lot of the things that we talk about in mental health is sort of like finding a routine and balance to help support you in your journey of recovery and management of symptoms. But then all of a sudden your routine is gone. You feel stuck in one place, losing your routine, additional load, worrying about so much extra stuff, especially worrying about finances. Many of the younger folks were kind of a little bit buffered if they had, parents and were of, middle class or upper class, but young kids who were taking care of themselves or who were low SES with less of a buffer, they really, really, really struggled. This is so important. I couldn't go outside, go to the gym, couldn't go for a swim. I couldn't go out and get fresh air. I was getting a lot of Zoom fatigue. It's funny that we're talking about this when we're on Zoom right now, but we won't talk about that. I wish I was with you guys in person for sure, but we'll talk about how sometimes Zoom can be beneficial too, especially for healthcare service delivery. People have different experiences of their personal health. So if you are unwell or you have disability, you're going to be more, as this person says, more worried than the average person. You're seeing stories about young people dying, people in healthcare dying. If I get it, I'm going to be so sick. There's no way out. People were so worried about their families. A lot of these people had dads working in Amazon factories and moms working in hospitals, and they were so, so, so scared. And then it really impacted their relationship with their families. They weren't seeing their families for months and months at a time, or their family was so worried they couldn't connect in the same way. And then in family relationships, I think that's why so much of the work that all of you do is so important, helping people like start the conversation about mental health, especially within their families. So people like not knowing how to talk to their families about this stuff, especially for people maybe who are of different cultural backgrounds or different. And culture can mean lots of things. Culture can mean like, in some families in rural Ontario or rural Nova Scotia, people like may not be an ethnic minority, but they have a very clear culture. And that means like not talking about mental health and not complaining about things, especially for men. Feeling isolated and alone, not having support, and then also like moving back into for some kids to the pressure cooker of their home where they felt like they couldn't breathe. Their parents were asking them about jobs and school. And, this is the one I meant. I don't have the privilege of, I know you all have the privilege to have a big house, but I don't. Interpersonal relationships. So internalizing loneliness, like not knowing where you stand with people and friendships. Virtual is not enough. I'm a person who likes to give hugs. I love that line. And I think this really surprised me and Elisa when we were doing the interviews. But this idea of moral choices, this kind of theme came out that anyone who took more precautions than I did was anxious or ridiculous. Anyone who took less precautions than I did was dangerous or cavalier. And so it was really hard for people to calibrate their moral choices. So losing friends, feeling judged, lost a lot of friends. Not everyone is as lucky as you who works from home, like all of these important pieces. Online schooling was a nightmare for many, many, many kids. I remember my daughter who's 12 now, 11 and a half. She'll be happy if I said she was 12, but she loves school. She's like one of those kids who's like built for school. Like she's like a school robot. She loves her friends, loves school. And she said to me, Mom, I feel like online schooling is like the worst parts of being at home and the worst parts of being at school. And that really stuck with me. And it came out in a lot of our interviews as well. And I know, you know, many kids were just sleeping through class, they're barely awake, they're beating themselves up, so much self-blame. And then mistrust of administration. I think we all probably felt that in our own workplaces. Like, are they're not taking it too seriously? Are people not being caring enough? Are there not enough flexibility? And then experiences of suicidality. So, how does all of these stressors kind of build a suicidal thought? So, existential dread, feeling so disconnected, feeling so alone, like I don't belong here. I don't want to continue living my life. Put a pause till the pandemic stopped. I think this is really important. It's not so much that I want it, and I think this is a line that resonates far beyond pandemic related suicidality. I think it's a key component of suicidality in general. It's not so much that I wanted to die, but I didn't want to keep living the life that I was living. If I can't focus on my studies, there's something wrong with me. I needed to focus on basic needs, not drown in suicidal ideation. And then the building intensity, worsening mental health, and then disrupted mental health care. I really draw your attention to the disrupted mental health care piece. People who were on antidepressants who just couldn't fill them, people who would go to emergency mental health services but wouldn't get referrals just because the whole system was so overrun. And then barriers to care. Again, these are COVID specific, but not really COVID specific. I think many of us who work in this field, we have so much moral distress about not being able to support people who we treat and people who we love and people we care about, and even ourselves sometimes in getting care. Wait times, cost and access, system navigation, this disconnect between emergency care versus long-term care. And I think if the pandemic does anything, it was a shared trauma that everyone had. And I think it shined a light on an already broken and fractured mental health care system. So people finally understood the importance of mental health and mental health care. And then I was like, oh God, people can't get the care that they need. And so people found that outpatient mental health care was so, so, so supportive, so helpful, working on a safety plan, processing, getting help, accepting myself, having a person to talk to. And I think this is so important. So I think sometimes we get in these like loops of what's better, virtual care or in-person care. And it was so cool because it depends on the person. Like, I think choice is so, so important. So some people love virtual care because I'm in my own space. It's super accessible. It reduced barriers. It becomes second nature. But other people really preferred in-person care. I want to be able to emotionally connect. It feels less artificial. It feels more real. I thought this was really meaningful. Always had people not believing how I feel. So if I'm in the room with the person, it helps. So I think that choice is so important. I think before the pandemic, we didn't have that choice, right? Like it was almost always in person. And then during the pandemic, it was kind of almost always virtual. But now as we come out of the pandemic, um, whatever that means, how do we balance in person versus virtual? And then recovery, self-care, communication and connection, mental health literacy was really, really important. And then these young folks had so many amazing ideas about how to transform mental health care. Affordable options, culturally safe care, a social safety net, longer term support, basic human needs to feel secure and safe, affordable housing, livable wages, food security. If you're constantly fighting for trying to get food or to trying to get these basic needs met, they're not going to be able to worry about their mental health. And how has your life changed? Really lovely thoughts around mental health awareness, reaching out to others, a sense of self changing and adapting, which makes sense given the phase of life as well. Like who you are when you're 18 is different than who you are when you're 24. And so especially when there's a seismic shift in your world in that time. And so those are our early findings. So, we have the information here that we'll share. If you or anybody that you know or work with or treat would be interested in participating with the study, we'll make sure that we send out this information. And here are some thoughts about how to participate, and we'll share this information with you. But I'm going to stop sharing my screen and then open it up to any questions that you may have. You guys have been so patient. I know 30 minutes of PowerPoint is a lot, but I'm hoping that we can chat a little bit more. If you have conversations about the research or the findings or conversations about the study itself, really, really thrilled to chat.
Perfect. Thank you, Juveria. So folks, I'm going to stop the recording right now. If I don't want anyone to feel uncomfortable during this time, and feel free to ask anything that's on your mind there. So we're just going to pause. Perfect. Thank you, Juveria, for that amazing presentation and sharing what you've learned so far from your study. And thank you to Elisa for helping us coordinate all of this and that. And appreciate everyone who took their time out of today to learn more about this study. And we hope that you share this information with others and encourage people to participate with it. So Alyssa and I will be putting together a package for you, which will include the recording here, the recruitment poster, the slides from the presentation today, minus any of the findings so far. Um, and encourage you to reach out to Alyssa if you have any questions about the research, if anything is still making you feel hesitant about it, or if you have folks that you know that might be interested in participating in it, they can connect either through a clinician or directly to Alyssa. And we hope that to just amplify Nova Scotians' voices in this research and have them well represented in this important work. So thank you so much, Juveria. Thank you, Alyssa. Um, and thank you everyone for coming today.
Thank you so much.
Thank you.